podcast created by members for members. I'm Katie Meyer, VP of Education at APHA. New to this year for the First Fill podcast, we are featuring the expertise, real-world experiences of members of APHA communities. Each episode is designed to spotlight APHA members with the goal of delivering timely, relevant education for our listeners. In this episode, we will be reviewing the 2026 ADA Standards of Care in Diabetes. These updates were just published back in December, and we will key in on important things for pharmacists to be aware of. Before we dive in, let me introduce my guest today, Kripali Patel. Kripali, why don't you introduce yourself?
Thank you, Katie. Thank you to you and APHA for having me here today. My name is, again, Kripali Patel, and I am an assistant professor of pharmacy practice at Massachusetts College of Pharmacy and Health Sciences in Boston, Massachusetts. I primarily work in the ambulatory care space at a federally qualified health center, practicing under a collaborative drug therapy agreement, primarily managing diabetes and hypertension in an underserved population. And I'm also a part of the APHA diabetes community, which is how I've had the opportunity to be here today with you all. And I really enjoy working with a group of very passionate pharmacists in regards to diabetes, education, etc.
Thanks so much, Kripali, for that introduction. So happy to have you on today. So let's dive in. So in our last episode, APHA member Justin Kirby and I reviewed updates to the standards of care that pharmacists should be aware of when treating patients who have cardiovascular disease, chronic kidney disease, and liver disease. In this episode, Kripali will review the ever so hot topic of weight management in diabetes. Should be aware, however, that there have also been extensive updates in the diabetes technology realm in the guidelines this year. ADA has actually changed classifications of the available CGM devices, and the new classifications include real-time CGMs, which are available by prescription only and have alarms, OTC CGMs, which are obviously available without a prescription and they do not have an alarm, and professional CGMs, which are used in providers' offices and also do not have an alarm. CGM is now really the mainstay of diabetes care, and APHA actually has additional education available on CGM, including a certificate training program. So be sure to check that out in our learning library if you're looking for more information. All right. Without further ado, let's dive into weight management. So, Kripali, what are the recommendations for obesity and weight management screening and some recommended non-pharmacologic or behavioral interventions that pharmacists can be recommending to their patients?
Yeah, so in terms of the American Diabetes Association recommendations for BMI screening, they recommend to screen annually for overweight and obesity with anthropometric measurements monitored at least annually and should be increased to every 3 months when patients are trying to actively manage their weight or lose weight. BMI is an easy measure of obesity and overweight. However, it may not be the best measure for patients who have low muscle mass or, on the other hand, athletes who have a very high muscle mass. So for those patients in particular, it's something to be mindful of. And again, anthropometric measurements may be more valuable. And again, those are the anthropometric testing or measurements are just waist circumference measurements and then waist to height ratio, etc. In terms of behavioral interventions, the ADA recommends intensive programs that have greater than 16 sessions over a 6-month period. These sessions should really be focused on nutrition changes, physical activity, behavioral strategies to essentially achieve about 500 to 750 calorie per day energy deficit. And when those programs may not be available for certain populations in certain areas, they can be delivered remotely or via telehealth, but in person is the preferred method. In terms of what can patients do, ADA does recommend 150 minutes of exercise per week, not just for weight loss, but for improved glycemic management and quality of life, as well as cardiorespiratory fitness. It is also highlighted this year in the ADA guidelines to make sure that we're counseling patients regularly on nutritional intake if they're pursuing weight loss. So part of this is ensuring they're having adequate protein intake, and the recommendation for protein intake that ADA has suggested is anywhere from 0.8 to 1.5 grams per kilogram of body weight, or about 15 to 20% of total daily calories. And the other things that patients can really focus on is reducing processed foods, ultra-processed foods, and encouraging more of nutrient-dense foods. ADA is also this year highlights a lot more of eating patterns versus focusing on a specific diet. So kind of looking at the totality of foods and beverages we're consuming versus diets, etc. And so some of the things that is highlighted within the guidelines in terms of nutritional or behavior changes to encourage weight loss includes having a lot of vegetables in diets, as well as legumes, fruits, and then foods that have at least 3 grams of fiber in one serving, again, to maintain sort of that glycemic control. And then the primary choice of beverage, they recommend is water. And if patients don't prefer plain water, they recommend adding slices of fruit or cucumbers, kind of to jazz up the water, make things a little bit more interesting. And so there are a couple of great recommendations in terms of heart healthy options as well within the guidelines that we can encourage patients to follow.
Thanks so much, Kripali. That was a lot of information on that non-farm strategy, with diet being really, really important in these patients. So great information for pharmacists to share. All right, let's shift gears to our bread and butter now. So how can clinicians and we as pharmacists integrate obesity pharmacotherapy into that comprehensive lifestyle intervention to maximize both short-term weight loss and long-term maintenance of metabolic improvement?
Yeah, so I think the key here is to individualize the initial treatment approaches for obesity. So for some patients, it may be pharmacotherapy, and making sure that we're basing our decisions based on the patient's medical history, their life circumstances, and their preferences. For example, some patients may prefer injectables, others may not, etc. Regarding the pharmacotherapy specifically, GLP receptor agonists or dual GIP-GLP receptor agonists with greater weight loss efficacy, specifically semaglutide or tirzepatide, are the preferred agents for patients with type 2 diabetes and overweight or obesity, given their added weight-independent cardiovascular benefits. In the STEP 2 trial, semaglutide 2.4 milligrams achieved 6.2% greater weight loss than placebo, with 1.2% greater A1C reduction after 68 weeks. Tirzepatide demonstrated even more robust results in SURMOUNT-2 with 9.6% and 11.6% greater weight loss than placebo with their 10 milligram and 15 milligram doses respectively, an A1C reduction of approximately 1.55 to 1.57%. So upon initiating these medications for obesity, we want to make sure that we're assessing for their effectiveness and safety at least monthly for the first 3 months, and then at least quarterly thereafter. In my practice, I find that this is especially important if patients are not meeting their weight loss goals or getting closer towards them. It's an opportunity to kind of reevaluate after the first 3 months to see if we can maybe go for another agent that may be more effective, or maybe we need to tweak something in the behavioral side as well. And it is important to make sure that we document these as with insurances. Sometimes step therapy, etc. options may need to be considered. And then lastly, one of the recommendations this year from ADA is around obesity pharmacotherapy is to continue long-term maintenance of GLP therapy for the long-term health benefits, as discontinuation often results in weight reoccurrence. And clinical trials show that sudden discontinuation, specifically of semaglutide and tirzepatide, results in recurrence of 1/2 to 2/3 of the weight loss within the first year. The treatment dose really should be individualized to make sure that we're balancing the effectiveness of the medication as well as the tolerability for the patient, and keeping in mind that the maximum approved dose may not be the best dose for every patient.
Thanks, Kripali, for that. Yeah, these GLP-1s and GIP-GLP-1 receptor agonists are really coming into play when we're treating patients with diabetes these days. So why don't we shift gears to that type 1 diabetic patient? The 2026 ADA guidelines now recommend applying some obesity management strategies to that population who has type 1 diabetes as well, including GLP-1, RA-based therapy. Thinking about that, what are some unique safety considerations that we have to address before initiating a medication like that in this population?
Yeah, so for type 1 diabetes with obesity, the ADA does recommend applying obesity management strategies used in the general population, including GLP-1, RA-based therapy, and metabolic surgery. However, this does require really careful shared decision-making because there are some unique safety considerations. Real-world data suggests benefits from weight reduction and A1C improvement with lower insulin requirements in type 1 diabetes. The adjunct trials showed that liraglutide 1.8 milligrams achieved approximately 6% weight reduction, but hypoglycemia rates increased by 20 to 30%, and hyperglycemia with ketosis risk doubled. Critical counseling points for type 1 diabetes patients include anticipating increased risk for hypoglycemia, maintaining adequate carbohydrate intake, testing for excess ketone production, and then cautious dose titrations with close monitoring of insulin requirements. So we really want to be monitoring very closely, especially when GLPs are added to the amount of insulin if a patient is on insulin already.
Thank you, Kripali, for going over that, and then just for such an insightful overview of the key updates to 2026 standards of care related to weight management today. It's definitely a great foundation and a very important and relevant topic for pharmacy. So I'm going to go ahead and summarize the discussion today. First, the American Diabetes Association recommends annual BMI screening for patients who are overweight or obese, with anthropometric measurements monitored at least annually and increased to at least every 3 months during active weight management treatment. Similar to what we reviewed in episode 1, GLP-1 receptor agonists or dual GIP-GLP-1 receptor agonists with greater weight loss efficacy, specifically semaglutide or tirzepatide, are the preferred agents for people with type 2 diabetes who are overweight or obese, given their added weight-independent cardiovascular benefits. GLP-1 receptor agonists are also recommended in patients with type 1 diabetes, but it's really important for pharmacists to counsel these patients on the increased risk for hypoglycemia, maintaining adequate carbohydrate intake, and cautious dose titration. For those of you who are considering attending APHA's annual meeting, we have a ton of content on the schedule related to diabetes this year. From rethinking CGM for today's patient to examining the real stars of Beverly Hills, GLP-1s, to treating patients with diabetes in all generations. If you make the trip to LA, you're sure to learn something new, so we hope to see you there. And in the meantime, APHA members, don't forget to head over to the Learning Library at learn.pharmacist.com to earn your CE credit for this month's podcast. Take care, and thanks so much for listening.